In today's class, we will be discussing about the echocardiographic aspects of patent ductus arteriosus. Patent ductus arteriosus is a common morbidity profile in preterm infants with extremely low birth weights. Its incidence is 80 to 90 percentage in extremely low birth weight infants less than 26 weeks, and its incidence is about 20 percentage at 32 weeks of gestation. Along with the morbidity associated with the patent ductus arteriosus, there are many neonatal complications which can result from a patent ductus arteriosus or PDA, which include neonatal necrotizing enterocolitis, bronchopulmonary dysplasia, respiratory support, cardiac failure, and so these are some of the common comorbidities associated with a PDA. So, what are the common echo views which we use in demonstrating PDA include the parasternal short axis view and the suprasternal view. Usually, the PDA flow will be velocity is less than 3 meter per second. Hence, we can use a pulse wave Doppler. And pulse wave Doppler in the main pulmonary artery show a quiet flow when the ductus arteriosus is closed, and it will show a turbulent systolic and diastolic flow when in the pulmonary artery and its branches when the ductus arteriosus is patent. So in this diagram we can see the 2D view of a main pulmonary artery dividing into LPA and RPA, and here there is no PDA, and hence the pulse wave put across this the main pulmonary artery is showing a normal profiling without any turbulence, that is laminar flow is being demonstrated in this pulse wave Doppler. While if there is a turbulence because of the PDA flow obstructing the normal MPA flow, here we can see turbulence which can be appreciated in the pulse wave Doppler profiling. So this is one easy way of detecting whether a PDA is present or not. So another important thing is most of the PDAs majority will close spontaneously, while how we grade whether a PDA is hemodynamically significant or not. To assess the hemodynamic significance of PDA, we have to take the size. We compare the LA by aortic valve size, and if it is more than 1.5, it indicates a hemodynamically significant PDA. So in this we use the M mode and Plaque's view, parasternal long axis view, and we take the measurement at the aortic valve at the end of diastole before the aortic valve opens, and the LA size is taken at the time of systole when the LA is maximal volume, and the ratio of LA by aortic valve, if it is more than 1.5, it indicates a hemodynamically significant PDA. So if there is here what it is happening is that from the systemic circulation blood is flowing into the pulmonary circulation. So here there is systemic steal is happening. So there can be reduced blood flow in the descending aorta as well as the superior mesenteric artery. So if there is absent or retrograde diastolic flow in the descending aorta, superior mesenteric or anterior cerebral artery, then it also indicates a hemodynamically significant PDA. And also based on the size. If the size is more than 1.5 mm at the narrowest point, then it is also indicating of a moderate to large PDA. It's also indicating a hemodynamically significant PDA. And if we put the pulse wave Doppler, and if we are getting a unrestricted pulsatile transductal flow, that indicates a hemodynamically significant PDA. Unrestricted means there is no restriction, there is no constrictions across the PDA, that is a continuous channel. Unrestricted means it is a continuous channel, freely blood is flowing from the aorta to pulmonary artery. If there is some narrowing or the PDA is trying to contract, there will be some constriction, so the velocity will be high. So in that case, we get a restrictive pulsatile transductal flow. It is not, it is indicating of a narrow PDA, or there is it is not a hemodynamically significant PDA. So here there are two 1.5. One is the LA by aortic valve size more than 1.5, and also the maximum narrowest maximum diameter at the narrowest point is more than 1.5 mm. So here this is the M mode in Plaque's view, in which we measure the aortic valve and LA, and LA by aortic valve ratio is taken. Here it is 2.06, so it is a hemodynamically significant PDA. So pulse wave Doppler we put. So here we are putting the pulse wave Doppler across the PDA. The transducer we place it in the postductal descending aorta. post-ductal descending aorta, we have to position the transducer. It is usually done in the suprasternal view. And here we can see three flow patterns. See here, this is the PDA, and if we put, we get a flow pattern like this. That is, this is the so in descending thoracic aorta, the probe is placed here, no? So the blood is flowing away from the probe, so we get a tracing below the baseline. So the flow is occurring below the baseline in both systole and during diastole. That means in diastole also the flow is below the baseline only. There is no flow reversal or absent diastolic flow. So this is a norm. This is not a hemodynamically significant PDA. While in this figure, we can see that the systolic flow is flowing, forward flow is there, and diastolic there is no flow. So it is an absent diastolic flow is happening here. And in this, in the pulse wave Doppler, in sagittal view, in the transductal PDA, when we put pulse wave Doppler, here we are getting a systolic flow, but there is a reversal of flow in the diastole. That is, above the baseline, we are getting a flow in the diastole. That is, reversal of flow is happening. So that is indicating of a hemodynamically significant PDA. And this finding is more specific in evaluating a hemodynamically significant PDA. So, in addition to the descending thoracic artery, we observe the flow in superior mesenteric artery. So, in superior mesenteric artery, we have to trace the aorta and the branches, celiac trunk and the mesenteric, superior mesenteric artery. And here the flow will be towards the probe is kept here. So, the flow will be towards the probe, because it's from the aorta it will go like this. So, in this we have to get both the curves across systolic and diastolic flow above the baseline. So this is normal flow. Here there is absent diastolic flow, and this is reversal of diastolic flow because we are getting below the baseline. So this is also indicating of a hemodynamically significant if there is reversal of diastolic flow. And now we put the Doppler across the PDA. So pulse wave Doppler is put across the PDA, and if there is a maximum velocity you are getting is more than 2 meter per second, that means that there is significant obstruction in the PDA and it is a restrictive PDA. And if the same 2 meter per second velocity is obtained in diastole also, that means there is significant obstruction. That is, so here what we take is, we take peak diastolic velocity is more than 50% of the peak systolic velocity, the flow pattern is restrictive. So that means it is not a hemodynamically significant. So if the ratio is less than 50% and the flow pattern is pulsatile, suggesting hemodynamically significant PDA. So in this B and C diagram, we can see that systolic and diastolic flow is almost like, here it is almost not much velocity difference in systolic and diastole. Here there is differences there, but not like the A diagram. So here there is peak diastolic velocity is taken at this point and peak systolic velocity is taken at this point. And if the here we can see that the peak diastolic velocity is more than 50%. Here also the 50% will come around here. Here also more than 50%. That means it is a restrictive PDA, not hemodynamically significant. While in this diagram, we can see that the diastolic velocity is less than 50%. So it is an unrestricted PDA. That is, it is flowing like a free channel. And there is significant steal, systemic steal is happening. So it is a hemodynamically significant PDA. So this is how we echocardiographically assess the significance of PDA, hemodynamically significant PDA. Thank you.